Hello viewers, today I would like to acquaint you with the topic access to health resources through my lecture. Introduction. Equity in health and equity in healthcare have been a long-standing guiding principles, with commitment to the serving the needs of the poor and the underprivileged being central to the health policy documents. The Health Survey and Development Committee report of 1946, led by Sir Joseph Bore, set out a detailed vision and plan for providing universal coverage to the population through a government-led health service. Since then, health policies and priorities have been outlined in the 5-year plans, developed as a part of India's centralized planning and development strategy. The first official national health policy, put forward in 1983, reiterated the need for universal comprehensive care. Influenced by Alma Ata Declaration, the policy emphasized the primary health care approach in addition to recommending decentralization of the health system, improved community participation, and the expansion of the private sector to reduce the burden on the public sector. While the next National Health Policy of 2002 continued to champion India's vision, this was to be carried out on the basis of realistic considerations of capacity. More recently, in 2009, the Government of India drafted a National Health Bill proposing the legal framework to recognize the right to health and right to health care, with a stated recognition to address the underlying social determinants of health. However, implementing policy commitments to equity in health care remains a challenge given India's institutional and implementation capabilities. Even though this is a challenge facing the global health community, and it is not unique to India, I conclude by arguing for the need to explicitly incorporate and implement an equity perspective in the development of a healthcare system in India, and propose a set of principles which are necessary to ensure more equitable healthcare for India's population. Inequalities in healthcare. The inverse care law, whereby those with the greatest need for health care have the greatest difficulty in accessing health services and the least likely to have their health needs met, is highly applicable in India. I conceptualize access as the ability to receive a specified set of services at a specified level of quality, subject to a specified constraint of inconvenience and cost, and use utilization of selected health services as a proxy for access. To illustrate the persisting inequalities and inequalities in healthcare in India, I have focused on access to maternal and child health services, as the disease burden relating to communicable, maternal and prenatal conditions are in part addressed by access to these services. Inequalities in preventive health care. Utilization of preventive services such as antenatal care and immunization remains suboptimal, with marked variations in the utilization of these services by gender, socio-economic status and geography. In 2005-06, the national immunization coverage was 44%. Inequalities in immunization exist by household wealth and education, with absolute and relative inequalities showing signs of reduction over time. Inequalities exist by caste. In 2005-06, immunization coverage among scheduled tribes and scheduled castes were 31.3% and 39.7% respectively, compared to 53.8% among other castes, with absolute inequalities between these castes increasing over time. Coverage remains higher in the urban areas compared to the rural areas, although absolute and relative urban-rural differences have decreased over time. Over time, the absolute gender gap has increased with an absolute 2.6% gender gap in 1992-93, increasing to 3.8% gender gap in 2005-06, shown in the following figure. Figure 1. Trends in inequalities in immunization coverage along different dimensions expressed in rate difference and rate ratio. Similar patterns in inequalities are seen for antenatal care coverage. In 2005-06, 77% of Indian women during their pregnancy received some form of antenatal care in the 3 years preceding the survey, even though only 52% had the recommended 3 or more visits. Overall progress in the antenatal care coverage has increased over time. Inequalities by wealth, education and urban-rural residents, however, persist, even though absolute and relative inequalities have decreased over time. For both these preventive services, there are considerable state differences, with both the number of antenatal visits and the type of services provided during these visits varying. Challenges to achieving equity in healthcare. Achieving equity in access to healthcare requires overcoming several factors that challenge equity in service delivery and equity in health financing and financial risk protection. On the supply side, I have discussed issues relating to achieving equity in service delivery, which ensure access to the appropriate level of well-resourced services, and on the demand side, we examine equity in health financing and financial risk protection and consider how the costs of seeking care may limit utilization, especially when out-of-pocket expenditures are extremely high. Supply side factors. Firstly, suboptimal and inequitable resource allocation. The inefficient allocation of resources between different levels of services and between different geographical regions is critical in ensuring the physical availability of the appropriate level of adequately resourced health services. In India, this challenge is compounded by low levels of public financing with marked state variations in financing. India's total expenditure on health was estimated at 4.13% of the GDP in 2008-09, with public expenditure on health being 1.10% of the share of the GDP. Private expenditures on health have remained high over the last decade, with India having one of the highest proportions of household out-of-pocket expenditure on health in the world, estimated at 71.1% in 2008-09. Central government per capita expenditures disbursed to states are relatively similar, irrespective of the different capabilities and health needs of different states. There is also wide variation in state expenditures on health, with a 7-fold difference between the major states. For example, public expenditure per capita in Bihar is estimated at 93 rupees compared to 630 rupees per capita in Himachal Pradesh in 2004-05. Besides interstate variations, a greater proportions of resources are directed towards urban-based services and higher level services, with 29.2% of public expenditures allocated to urban allopathic services compared to 11.8% of public expenditures allocated to rural allopathic services in 2004-05. This imbalanced allocation is compounded by the private sector's bias towards higher level curative services, which, determined by market forces, tend to be centered in the wealthier urban areas. The private sector dominates service provision of high-end curative services, and evidence from National Household Surveys demonstrates the expanding role of the private sector over the last 2 decades, emerging as the predominant provider of inpatient care. Physical access. Physical access is the major barrier to both preventive and curative health services for India's large rural population. The number of government hospital beds in urban areas is more than twice the number in rural areas, and the rapid development of the private sector in urban areas has resulted in an unplanned and unequal geographical distribution of services. Although urban concentration of facilities may encourage economies of scale, the distribution of services is an important factor affecting equity in healthcare, primarily as many vulnerable groups tend to be clustered in areas where services are scarce. In 2008, there were an estimated 11,289 government hospitals with 4,94,510 beds, with marked regional variations ranging from 533 persons per government hospital bed in Arunachal Pradesh to 5,494 persons per government hospital bed in Jharkhand. As physical distance to facilities is a key determinant for access, overcoming this through outreach or better transport, roads and communication networks is important for reaching disadvantaged and physically isolated groups such as scheduled tribes. In addition, distance remains a greater barrier for women. Furthermore, physical access of services does not necessarily assure utilization, since the costs associated with seeking care also preclude uptake even when services are physically available. Human Resources for Health India faces the challenge of sustaining adequate level, skill mix, quality and distribution of human resources for health across states, especially in the poorer rural areas. Rural areas are served by over 1 million rural practitioners, many of whom are not formally trained or licensed. Since the most disadvantaged are more likely to receive treatment from less qualified providers, India's human resources for health challenge presents a further hurdle for assuring equity in health access. Quality. Quality is a complex construct capturing several different parameters such as safety, effectiveness, timeliness and patient-centeredness, and can be broadly divided into service and clinical quality. In India, quality in healthcare is not well understood, with limited evidence to ensure and infer how quality affects equity in healthcare. Adequate regulation of the public and the private sector has been difficult to achieve. Even though there exists a complex regulatory framework with an extensive set of legal instruments such as the Indian Penal Code, the Indian Contract Act and the laws of torts, effective enforcement and implementation remains problematic. Studies suggest that there is high absenteeism among health workers, limited opening hours, limited availability of drugs and other supplies, poor physical environments and poor provider training and knowledge. In urban centers, low competence among both private and public providers has been documented, with providers visited by the poor being less qualified and knowledgeable. A study in rural Rajasthan reported that most private providers were unqualified, with fewer than 40% have a medical degree and almost 20% not having completed secondary school. Dissatisfaction with the quality of care in the public sector is proposed as the reason that the poor seek care in the private sector. Reducing the exposure to clinically unnecessary and potentially harmful treatments and influencing demand for appropriate health seeking are emerging as important issues. As the disadvantaged and poor are more likely to receive poor quality services, this has important implications for assuring equity in healthcare. Regulatory deficiencies in the private sector were partly redressed by the inclusion of the private medical practice under the Consumer Protection Act in 1986, with recognition of patients' rights and resolutions through the consumer forums. Other authorities involved with regulating the private sector include the Central Drug Standard Control Organization, National Pharmaceutical Pricing Authority, state drug controllers, and the Nursing Home Acts of different cities and states, and until recently the Medical Council of India. Demand side factors. Firstly, financial constraints to demand. Low levels of public financing, lack of comprehensive risk pooling mechanism, and the high out-of-pocket expenditures in the context of rising health costs are key factors impacting equity in health, financing, and financial risk protection. Evidence from national expenditure surveys suggest that inequalities in health financing have worsened over the last 2 decades. Only around 10% of the Indian population are covered by any form of social or voluntary health insurance, which is mainly offered through government schemes for selected employment groups in the organized sector. For example, Employee State Insurance Scheme, Central Government Health Scheme. Private insurance entered the Indian market after passage of the Insurance Regulatory and Development Authority Bill in 1999, and private insurance companies account for 6.1% of health expenditures on insurance. Community-based health insurance schemes and schemes for the informal sector, which encourage risk pooling, cover less than 1% of the population. Thus, out-of-pocket expenditures and the associated inequities predominate. The poor are more price sensitive to healthcare. They are less likely than the rich to seek care when they are ill, and this is more so in rural areas. Moreover, the poor are more likely to report financial cost as a barrier, as the reason for foregoing care when suffering from illness, and this can be increased over time for both the rural and urban poor. The cost of maternal care, for instance, is out of reach of the poorest households, where the average costs incurred during the year of childbirth exceeds their annual capacity to pay. Principles to achieving equity in healthcare. Firstly, equity metrics. Equity metrics need to be integrated into all health system policy and implementation strategies, and at every stage of any reform process. Recommended by the Commission on Social Determinants and others, this entails applying an equity-focused approach to the collection, use and application of data on health outcomes and processes of healthcare, and during monitoring and evaluation of the health system's performance. This requires an intelligent system built across the health system network, spanning the public and private sector, and allopathic medicine and non-allopathic medicine, Ayurveda, yoga and naturopathy, Unani, Siddha and homeopathy, that means Ayush, aligned with international principles and standards for health metrics. For instance, Thailand's experience of building capacity for equity monitoring and strengthening partnerships between data collection bodies and its Ministry of Public Health fostered the development of health equity monitoring. While India has the benefit of rich data sources, these could be better applied to monitoring changing equity gaps and quantifying progress among disadvantaged groups. Furthermore, equity-based targets need to be fully integrated into the national, state and local level goals. Capacity building for health systems and health equity research. There needs to be a concerted effort to improve the knowledge base of health systems research and health equity research. India is in the position of taking a leading role in improving our knowledge of health systems research at the global level. Given that much of the implementation and decisions are made at the state and local level, there is the opportunity to actively learn from the multitude of different reforms. However, it is imperative at the outset that optimal data management systems and research designs are in place, so as to capitalize on gaining knowledge from these interventions and understanding which programs and interventions work and how they impact the equity in healthcare. This is even more important given the iterative scaling up and rolling out these reforms to guide where resources should be most effectively directed to improve the likelihood of success. Although there have been independent and internal evaluations of the National Rural Health Mission, both of specific programs and in specific states, there is an urgent need for further independent large-scale evaluations. During Mexico's recent health sector reforms, their evidence-based approach to impact evolution allowed the world to learn from their experience. India must adopt such an approach of rigorous impact evolution and implementation research, ideally with a specific body commissioned with coordinating and disseminating this knowledge developed through an active sharing of best practices between and within states as well as internationally. The National Health Systems Resource Center is well placed to provide the necessary structure to support this and facilitate the ongoing development of the health management information system. Partnering with research and academic institutions to objectively assist with this process and harnessing their expertise in the methodological aspects of impact evolution will create the knowledge base to more effectively pursue equity in healthcare. Such a commitment must be supported by more resources and increased research funding to coordinate this. In this way, India can contribute to the limited knowledge base of operational research in health systems in developing countries and help close the knowledge action gap in health systems strengthening. Deliberative process of achieving equity in healthcare, there needs to be more meaningful consideration and development of decision-making process relating to achieving health equity. We have only touched on some of the challenges that India's health system faces from the equity perspective. Yet, the central issue concerns not only what needs to be done, but how to go about achieving this. The challenge of how to prioritize and implement pro-equity health policies when resources are limited requires a deliberative process. This requires taking into consideration the implications and risks of those decisions with monitoring of how such decisions will affect health equity. For example, epidemiologic polarization and the emerging burden of chronic disease require making choices for the allocation of resources between subpopulations with different disease pattern. Further, with India's aging population requires deliberation of intergenerational equity in the allocation of limited resources between different age groups. Therefore, it is suggested to review and formalize the process of resources allocation decisions and the service delivery planning, which involve deciding the balance between central, state and local financing and the vertical and horizontal allocation efficiency based on the best available evidence and guided by equity concerns. This could involve adoption of a framework such as benchmarks for fairness, which has been successfully adapted for use in several developing countries such as Colombia, Pakistan and Thailand. Mexico's experience of embracing a transparent decision-making process for prioritizing coverage of specific health conditions under their social reforms, together with specific inputs from an ethics working group, created a forum for reasonableness which was relevant, revisable and enforceable and ultimately more legitimate. This is important in addressing the supply side issue of allocation of limited resources to different service inputs. Such an approach requires all stakeholders to take responsibility and together engage in the pursuit of reducing inequalities in healthcare and health in India. Stakeholders' responsibility and accountabilities. Multilaterals, national and local government, NGOs, the private sector, pharmaceutical industry, civil society and research and academic institutions all have responsibility and roles to play in ensuring the success of achieving equity in health and indeed better health governance. This requires demanding accountability, transparency and better leadership and partnerships within the health system, together with systematic assessment and analysis of health system governance. Since health policy and implementation manifestly operates within the broader political context, defining iterative strategies for key players to maintain political priority for the equity in health agenda is necessary to champion this issue. This is particularly important because the potential beneficiaries represent a less powerful and less organized group who are consequently less able to influence these reforms. We specifically highlight the role of civil society and the need to engage, empower and build capacity within civil society to demand equity in health and better quality health care at the reasonable costs. Although the evidence to support this may be lacking, examples such as China's experience of public dissatisfaction with the fairness of its health system demonstrates how civil society can effect change in health reform. Critically, India's ineffective regulatory mechanisms and legal instruments urgently need to be reformed and effective implementation strategies. The growth of private sector and pharmaceutical industry has outpaced the capacity of the government and other stakeholders to institute the necessary and appropriate regulatory environment. Incentives, rules and strategies are needed to engage and persuade the industry to ensure that their obligations and responsibilities to population health and equity are upheld. This current deficiency could redefine the potential role of a more organized civil society in shaping the political agenda. In part, this can be achieved through dissemination of knowledge and improvements in education to generate better health consciousness and address the demand side challenge of appropriate health seeking behavior. For example, engagement of accredited social health activists as a part of the National Rural Health Mission to generate more awareness within communities of the available services. This should be complemented by improved awareness of the right to health and the right to health care and the obligations of the health systems and government, institutions and other stakeholders to delivering this fairly. Investing in public health and primary care, cornerstones for equity in health. Finally, priority should be given to investing in public health and primary care. Improving the existing fragmented approach to public health services through creation of a solid foundation in public health paralleled by strengthening of the primary care network would go a long way in ensuring a more equitable, healthy India. Building the capability and capacity to plan and implement public health services from within the Ministry of Health and Family Welfare would allow for a more coordinated approach to effectively protect the population's health. Stronger engagement and partnerships both within and outside government are needed to improve public health infrastructure and better protect the most vulnerable from unjust exposure to adverse risks. Such investments in public health, together with strengthening of primary care services and targeted programs to reach out to those most in need, is a fundamental step towards readdressing the health inequalities that exist in India. Primary care is arguably more complex and uncertain compared to the time of the Alma Ata Declaration, but building a responsive integrated primary care service which ensures universal coverage is also a means to contain costs. The 11th Five-Year Plan and National Rural Health Mission both emphasize the foundation of primary care and further promote a holistic approach to intersectoral responses to complement this. Conclusion: this is a cogent moral, social and economic argument for investing in achieving equity in the health care of Indians. Recent rapid economic growth provides for a unique opportunity to increase financial commitments to support the public health system and health systems research. India can also draw on the knowledge capital of its booming technology sector to innovate and strengthen the development of health information systems, which has already begun. Furthermore, there is the opportunity to harness the capability of the domestic pharmaceutical industry by inducing it to take greater responsibility for delivering equity in healthcare. I have suggested principles to guide this vision. The next step is translating these into real and practical policies and effectively implementing them, and the call to action takes up this challenge. Yet, this focus on the role of health system needs to be placed within the broader and bigger context of the social determinants of health and tackling the root causes of social disadvantage. In this way, a health system built on the strong foundation of public health and primary care must be synergized with public policies that promote critical intersectoral approaches. Improved water and sanitation, food security, poverty reduction and changes to other structural factors complemented by more equitable health system will help ensure more equitable health for more than 1 billion people. So this was all for today. Thanks for watching this program. Thank you.